Hi everyone, thank you so much for being here today. I'll just introduce myself. My name is Alicia McIntosh. I am a manager in the NHS, formerly a nurse by background, which helps with this kind of thing. So I worked at Evelina London Children's Hospital with Jonathan at Guy's and St Thomas's in London. Thank you so much for having us here today. Really hope this is going to be useful or helpful or interesting. And we're both here today to talk to you about Paediatric Inflammatory Multisystem Syndrome, or PIMS-TS as we had this abbreviated to. Our presentation today is going to be mainly with a focus on our discoveries that we'd made about the ethnicity of the children that we'd looked at and the socioeconomic background and the kind of impact this has in childhood COVID-related outcomes. Jonathan and I just both want to give thanks to the whole paediatric team, the Evelina. We did not do this by ourselves. We had lots of help from lots of people. So yeah, Jonathan is the main star behind the paper, however, so I'm going to hand over to him and let him do a bit of an introduction and get us started.
Thanks, Alicia. It's definitely a dream team, but I will carry on. So today we're going to talk a bit about the background to why we did this paper and introduce a case study. We'll talk about the sort of epidemiology findings that we had from the paper. There's going to be lots of discussion throughout, and we want you to take part in the chat as we go. We're going to have questions, so please do put your thoughts as we go. We are hoping to be there if connection allows, and we will be answering on the chat the questions and thoughts as we go. And then we're going to talk about next steps and advocacy. So first of all, case definition. So you may know that the UK uses a slightly different definition of PIMS-TS than other countries, but for us, we talk about fever, evidence of inflammation, and single or multi-organ involvement. So that might be gastrointestinal symptoms, as well as headaches or skin symptoms such as rash or eye changes, in the absence of sepsis. So that rules out PIMS-TS, and you may or may not have had proven exposure to COVID, but it's expected that most people did. So on to a case. So this is a case I saw with some changes and obviously anonymized. So a 15-year-old boy who came to the emergency department with 5 days of fever and abdomen pain, diarrhea and vomiting, chest pain and eye changes, big red eyes. He's feeling generally unwell, off feed. He's normally very well, very active, played football for a local team. He himself had no cough, but he thinks his dad had a cough about 6 weeks before. His background is that his mum is working in a care home. She was initially trained as a nurse, but that wasn't recognised here, so she was kind of a healthcare assistant in a care home on a 0 hours contract. His dad works in security, and he has 4 siblings who live at home together. The initial management was treated as likely PIMS-TS, but also covered for toxic shock with IVIG, methylpred, IV antibiotics to cover for possible toxic shock and thromboprophylaxis. He had initially worsening coronary artery disease, and he actually had worsening shock and then ended up in intensive care for 6 days on inotropes. But with immunomodulation, he made some improvement. He was getting better, and I saw him at follow-up, which was 1 month later. He remained tired, distracted, he lost a lot of energy and had recurrent abdomen pain. So I'm going to hand over to Alicia.
Hi, so this is the point where straight away we want to get you considering a little bit about this case, any questions, any thoughts. So hopefully, obviously, we'll be here on the day to facilitate this, but just in case not, going to pose these questions to you and give everyone a minute to just write in the chat box, discuss amongst yourself, however is easiest. But a few things we wanted to consider with the case that we've just presented. How does everyone think the social factors might have contributed to this presentation of PIMS-TS? How might the child's PIMS-TS then have an effect on the family? And if anyone has any anonymized cases from their own practice of patients where you can see that social circumstances have impacted on their health during any time of the pandemic, COVID related, not COVID related, whatever you think is relevant or helpful or kind of links into this a little bit, please share this in the chat. Let us know. And yeah, we'll just pause for a minute to give everyone time to collect their thoughts and do that. I'm going to set a little timer.
And just as a reminder, the social history for this child was that he had a mum who was working in a care home at the time, and he had a dad who was working in security at the time, and he was in a family of 6 people. Yeah, and previously very healthy boy, very active, and played a lot of football.
So we're just coming up to 1 minute, so give everyone a few more seconds while I talk, and please feel free to keep sending on anything. Yeah, it's really good to just get everyone's thoughts and experiences, see if people have noticed any similar trends. So on from that and what we've discussed, so why is it important that we study ethnicity and socioeconomic factors, and in this particular case, how this had an impact on childhood COVID exposure? Of course, as we all know, ethnicity and socioeconomic factors, they'll intersect on nearly kind of everything that can influence your health on a day-to-day basis, everything that can influence you in your personal life. And I think COVID that we're seeing in children, or the effects of this, are no different. A lot of people might have seen UNICEF, lots of other kind of big publishing journal articles and stuff have put out articles describing children as maybe the biggest victims of COVID, or the most overlooked, or the invisible ones. And just because classically then maybe not as unwell, of course, children's lives have been changed in profound ways. And all of this really does kind of link back to poverty, with that secondary focus on ethnicity, but obviously ethnicity being linked to poverty and kind of a poorer socioeconomic status. So as we move on, the data we're going to show you from our own cases that we saw at the Evelina with PIMS-TS, we can really draw quite a link between ethnicity and adverse outcomes linked to PIMS-TS. So for Jonathan and myself, and I think for most of us that might have observed anything similar through the pandemic, really goes without saying that it's very important to continue to study these links, because that is the way we're going to be able to improve our practice and ultimately improve outcomes for children and the children that fall into these groups that are particularly vulnerable. And that was just something that was very important for us to emphasize with the outcomes of this article. So we can kind of move on to the next slide. I'm just going to explain a bit about the methodology and how we've, got this data and come to these conclusions. As a manager, this was where I was able to mainly help Jonathan out with the data collection. So we have taken a cohort of our patients that presented with PIMS-TS at the Evelina Hospital between March 2020 and June 2020. And after this point, we've just done a big retrospective audit of all the children. So what we've done is just very simple, collect their ethnicity group as self-identified by either, the child or generally their family, what was noted on their medical records, and also the parents' professions, and then a bit more of soft intelligence about what was going on in the household, other people in the household. So we've taken all of this data very simply for each of the children, and then what we've done is we've compared this both with the national statistics and demographic population, and also the demographic population of the areas that we cover in London, which are known as Lambeth and Southwark. So all of this, we've done our collection, we've talked to the research and auditing teams at the hospital just to make sure that they've approved us, given us authority to collect this, and that we've done it in the right manner. No big issues or barriers really with us collecting that information. It was kind of minimally disruptive to the patients and their care and their families, of course, but it was just really helpful for us to begin kind of compiling all this research together. So what did we find out from this, looking at our results? So this is just kind of a breakdown, obviously, of the cohort of patients that we looked at. You can see here we were seeing a lot more male cases than we were female, and it's just kind of straight away, without any kind of fancy analysis, you can see that our cases are weighted more in the more deprived end of the quintiles on socioeconomic status, so 1 being the most deprived and quintile 2, and you can see quintile 5 with the least deprived, we've kind of had the least amount of instance here. Breaking it down to ethnicity also, just going to caveat the data here and say that for, mixed and other, we've generally got very small numbers. So some of the results in this, we just need to, take that into consideration. But the proportion of cases we've seen here broken under the white ethnicity group, 18, and 38 under a Black African Caribbean or Black British group, much more heavily weighted towards that group, despite although we do have a much higher rate of Black African Caribbean individuals in Lambeth and Southwark, the population that we serve, it wasn't this disproportionately high in our local population. So those were kind of our initial results once we'd compiled the data that we were able to see. So when we put this a little bit more visually and we kind of display the quintiles by ethnic group here, you can straight away see, of course, how it's weighted much lower in the Black African Caribbean group, down at quintile 1 and 2 compared to the other ethnic groups, where we do notice some disproportionate outcomes with kind of Asian or mixed groups, but for the smaller numbers in there, you can see kind of the stark difference between children from a white ethnic group and children from a Black ethnic group here, very overrepresented in the most kind of deprived quintiles. And yeah, Jonathan, I'll hand back to you to discuss. Oh, sorry, yeah, no, still going on me looking at a different slide on my screen. Sorry about that. Yeah, so the final bit that we had to analyze, which I mentioned earlier, was about the parents and what they were doing during the pandemic. We know, obviously, as you can imagine, socioeconomic status, if you're more deprived, you're much more likely to be a key worker and not able to self-isolate during the pandemic. So the results that we're seeing here, a little bit confusing how we've compiled it, but basically you can see region 2, region 1 that we're comparing against our own cohort in Lambeth and Southwark in South London, much higher representation of parents that identified, or parents or someone in the household, primary carer for the child, that are working in healthcare, and also people that are key workers. And by that, we've kind of let the parents and the family self-identify whether they're key workers or not, which did pose us a couple of issues and questions, but generally all of these people are leaving the house for work regularly to go into contact with a lot more people through their commute. So again, the second thing we saw was that the children in the cohort that we studied, much more likely to have family members that were out for work, which we know is linked to their socioeconomic status. And now I'll pass on to you, Jonathan.
Thanks, Alicia. And I'll just add one more thing, which is that even families that weren't key workers, we often found that they continued to have to work during the pandemic, although we don't have accurate data on this, but we did think it was the majority. So one last thing I'll just add about the background of the cohort. So the vast majority were from kind of the dense inner city parts of London, as you might expect. And this is a map just representing that. And the blue star is where the Evelina is. So I just wanted to do some comparison to population. This is a big slide, but essentially what we are looking at is the odds ratios for our patients in comparison to the population. So if you look at the amount, so if we start with deprivation decile or quintile, you can see that the percent of the population, as you might expect, is roughly even between the different quintile groups. But if you start in the most deprived quintile, which is quintile 1, you'll find that the rate per 100,000 for PIMS-TS was much higher, it was around 8, if you compare that to the rate per 100,000 in quintile 5, which is 1.6. So for the most deprived quintile, this correlated to an odds ratio of about 5 times. So their kids were 5 times more likely to have PIMS-TS than compared to quintile 5, the least deprived quintile. Now, if we look at ethnicity, we compared this to children from white ethnic groups. We did this because that was generally how it was being done in other papers. And you found that the odds ratio, if you looked, the children from Black ethnic groups have a 15 times higher odds, roughly, of having PIMS-TS in comparison to the white kids. Now, I'll take the mixed and other ones with a slight pinch of salt because they're very small groups, but the Asian group, children from the Asian group were also had higher odds. Now, this was initial data for the first 3 months of the pandemic, and that effect was slightly dulled in later months, we think. but the kind of trend and direction was definitely seen throughout has been seen throughout the pandemic. So I just want to do some comparison. So if you think PIMS-TS, I just presented those odds ratios. So the kids from Black ethnic groups were sort of 15 times more higher odds compared to white to have PIMS-TS. Now, if you look at adult populations in COVID, that was a very different story. Well, sorry, it's the same story, but very different numbers. So adults from Black ethnic groups were more likely to have COVID generally in that time, and they were much more likely to be hospitalised. So 4 times higher odds of being hospitalised and 1.3 times higher odds of having infection with COVID. But the effect was much greater in PIMS-TS for children. And there's a lot of questions that remain to be answered about why that effect was much more magnified in children compared to adults. And we will invite you to think on that slightly later. In terms of children getting PIMS-TS, so there was a higher odds ratio, as I mentioned, for children from Asian backgrounds having PIMS-TS, and this was consistent with adult infections, but again, slightly higher. So 4 times higher odds of having PIMS-TS compared to children from white backgrounds, but that's compared to 1.2 times higher odds of having COVID infections and 2.1 times higher odds of having hospitalisation. So that is to say that the risk to children from PIMS-TS was higher than that seen in adults for COVID, either infection or hospitalisation. So now I want to talk about severity of PIMS-TS. So again, these are small numbers, but essentially, if you first talk about ethnicity, we found that the length of stay was slightly longer. It looked to be slightly longer. So the kids from Black backgrounds had a sort of median length of stay of 8, compared to length of stay for children from white backgrounds, but again, these are small numbers. In terms of PICU admission, you can see that the kids from white backgrounds had a sort of 56% probability of being admitted to PICU, compared to 74% in children from Black backgrounds and 57% from Asian backgrounds. And mixed and other backgrounds are very small numbers. In terms of ventilation, again, these are really small numbers, but we found that most of the kids that needed to be ventilated were from Black backgrounds. And in terms of those kids that needed inotropes, we found that the kids from Black backgrounds were the sort of largest cohort represented that needed inotropes. So that is to say that for measures of length of stay, needing PICU, inotropes, and ventilation, children from Black ethnic groups seem to be the highest risk. We found the same thing. We found a similar finding with deprivation. So we found that kids from the most deprived quintiles had slightly longer hospital stays. And again, these are small numbers, but you can see there's a sort of trend in terms of length of stay. In terms of PICU admission, we found that children from the most deprived backgrounds were most likely to need PICU, and had ended up being ventilated. So 27% of kids from quintile 1 need to be ventilated compared to none of the kids from quintile 5. And the kids that needed inotropes, again, there was a sort of trend, and the kids that were most deprived needed the most inotropes. So when we put this in a multiple regression model, now I'm not a statistician, so this is really here for the most keen of you who are very into statistics, but essentially I'm going to summarize what the statistician told me that this model finds, which is if you look at this right bit of the model, that bit of the model does not include ethnicity in the model. And what you find is that deprivation was a significant predictor for length of stay. And we found this with the other measures of severity as well. But when you then included ethnicity, that effect was overshadowed. So the left bit of this graph basically shows the odds ratios, regression coefficients, sorry, for all of the factors if you include ethnicity in the model. And essentially what you find is that black ethnicity was a big predictor of need for longer hospital stay, and we found this with other findings as well. So taken together, these data suggests that there was a very inequalizing effect of COVID, which was probably underpinned by both structural and social factors. And we found that children from Black, Asian and other ethnic minorities were more likely to have PIMS-TS, and children from deprived socioeconomic deprivation quintiles were more likely to have PIMS-TS, and that children from Black ethnic groups were more likely to have longer hospital stays and a need for ventilation. We obviously have to take all these data with a pinch of salt because they're very small numbers, but these were initial findings that have been complemented by our later experiences of the pandemic. We think there's likely to be an interplay of factors, intersectional regions for the increased risks that we found in these groups. There might be some biological factors, although these are often considered quite controversial, whereas social factors seem to be underpinning it, such as housing and unemployment. Now, we really know that there's a heavy preponderance of healthcare workers and key workers in our group, which suggests an employment risk. We also want to say that there's obviously bias in healthcare, bias in public health, and this has been seen during the pandemic with an unequal effect of some public health interventions, which is a really key thing for us to focus on in terms of next steps. We also think that structural barriers to healthcare, such as the hostile environment policies measures, really will need to be overcome, and this has consistently been cited by key stakeholder groups as a barrier to healthcare for certain groups, and that we need to have a redoubled effort to think about universal access to healthcare, vaccines, and public health. So last things I want to say about our findings are that the risk to families from ethnic minority groups, and particularly key worker families, is really quite noteworthy and needs more work. We found that when we looked at the data for London, ethnic minorities were consistently overrepresented in key worker professions and healthcare worker professions. And at the time of the paper, there was consistent finding that doctors and healthcare workers from ethnic minority backgrounds felt less able to raise concerns about PPE, and we know that PPE was a major problem at the beginning of the pandemic particularly. All these data together suggest the importance of acting on the wider social determinants of health, not just for PIMS-TS or COVID, but more generally. So I'm going to hand over to Alicia, thanks.
So again, just want to make it a bit more interactive here and just kind of repeat what we've done earlier. A few more questions to consider for people to share their own experiences. So what we're highlighting here is what can we learn from the inequalizing health effects that we've seen during COVID? If anyone's got any key learning points or things that have kind of been, been made very aware to them or playing on their mind through the pandemic, great to hear. Would be really keen to facilitate discussion in how can we reduce bias in our own medical practice. It's something that everyone needs to consider, absolutely everyone. We're surrounded by bias and injustice from the day we're born to the day we grow up, and it impacts all of us in some way in our practice. And it's just that kind of continuing learning of how can we overcome that, how can we make sure that we're definitely treating everyone equally, not just ourselves, but our organisation, our colleagues, and how can we advocate for like equal healthcare, particularly within children's health, for everyone here that's interested in this kind of area. Anything you've seen, anything observed that you've learned or that anything that particularly affects our vulnerable paediatric patients would be great to share. So we'll give everyone a minute again. If you write your answers in the chat or we all have a discussion, that'll be great. Just pause for a minute. Okay, so hopefully we've got some good thoughts there. Hopefully Jonathan and I will be there on the day to maybe discuss this bit with you. But yeah, sure, it'll be really great to hear everyone's thinking on this. So after that, we just obviously wanted to finish off by signposting. Again, neither Jonathan or I are experts in this, despite having done the paper, but there definitely are a few helpful links and stuff we can signpost to. Skin Deep is literally what it says there. It's a website. They're trying to improve the kind of diversity of skin images you can find online related to medical conditions. So obviously a lot of kind of dermatology related things here, rashes, certain, you know, disease identifiers that you might see. There's definitely a lot of resources and people out there trying to advocate for this and for, you know, us to be taught in nursing and medical school and whenever we train about how different conditions will present on people with different skin tones physically and also in the symptoms that we're reporting. And we've got further resources signposted below as well about poverty and poverty in children's kind of health. So those are a few with kind of like practical and practice sides of diagnosing. And then we've got another slide. So again, more websites, people doing really great work. So the Race and Health Organization, signposting lots of research, action groups going on, ways we can all take action. Definitely a good one to go and look at. Melanin Medics are a network of medics. They run events, resources, conferences, lots of really interesting work going on there for anyone else that's interested. MedAct advocacy and research. Again, just lots here about social justice, economic justice. They have these two different streams that Jonathan's put there about race, health, justice, and economic. So depending if one or the other took your interest a little bit more, but really good to kind of see both channels of socioeconomic factors and racial factors both being addressed there. And then, of course, wherever you're training, wherever you're based, generally these days, most trusts and organizations will have their own BAME network, staff networks that you can get involved in. Another really great way to be able to address, do something similar to what we've done, do some research, write a paper. There's definitely always gaps there that we're able to look at. And of course, medical colleges, the Royal College of Physician and Child Health, all these kind of governing bodies for us are all going to have equality and diversity streams and ways that you can also get involved and take action. So definitely have a look at all the resources out there, everything that's offered. It could be really, really interesting. And yeah, just something that's really rewarding to get involved with, basically. So thank you so much for listening. Hope that was helpful again. We just wanted to acknowledge, of course, when we were doing the paper and when Jonathan and the team were actually treating kids with PIMS TS, we had such a multidisciplinary range of involvement from all of the specialties listed there and probably more. So it really was a big team effort. And both of us are more than happy to be contacted for any questions, anything further, discussions, keep in touch, anything at all, just please drop us an email on either one of the two. Would be more than happy to answer and have a chat or set anything up.
And if our connection is permitting and we have been able to join, then we will be on the chat now for any other questions for the next couple of minutes. So thank you so much and enjoy the rest of the day.